You're not alone, together we're strong.
But my name is James Roberts. I'm with Find Help for Cancer, and I'm a patient care coordinator. So I simply help cancer patients find the appropriate facility, whether that's in Canada or in the United States or in Mexico. So we simply start with a conversation and then help you find and connect with facilities that are going to meet the needs. I've been doing that for about 13, 14 years now. It's probably, I don't know, 15 to 20,000 conversations at this point in time. It's a lot of conversations with cancer patients, and hearing people's stories. So that's and there's lots of information on my website, which is the Find Help for Cancer website. But I met Dr. Lemmo, very impressed. Not only is he a great doctor, but he's a great researcher. And when you look at Dr. Lemmo's videos, and coming from a patient care coordinator perspective, I'll hear questions regarding medications or treatments, and there'll be studies that will come out regarding those treatments and studies, and then the Dr. Lemmo is simply breaking that down, showing what's meaningful out of that information and what is potentially bunk, so that you can make a patient can make some good decisions moving forward. But Dr. Lemmo, I wanted you to give a little background on yourself, and then we were going to discuss the hyperthermia and all the benefits for hyperthermia.
Great, thank you for that wonderful introduction, James. So we're introduced to each other from a dear friend and colleague who had nothing but great things to say about you, and working together and collaborating with you. So a little bit about myself. So I've been in practice since 1999, so almost 27 years now. I've had a practice solely focused in cancer care for over 20 of those years in my career. So breakfast, lunch, and dinner. I also became a fellow of the American Board of Naturopathic Oncology, or FABNO, earlier on in 2009, just to be around other fellow colleagues with interests in cancer care. So at this point in my career, when you're talking about these videos, I think what prompted me to do a lot of these videos was just to provide more honest assessments on things that were published. There's obviously even some information that should be talked about in the news and it's not talked about in the news. And so I try my best just to create an awareness, because I'm finding that sometimes it's not really shared to people by their oncology teams, their networks, and yet some of these things are published in peer-reviewed journals and yet not really mentioned to patients at all. So I try my best in that area as well. So thank you for supporting and those videos and giving me a positive plug there. I try my best, and I try to make it as just layman friendly as possible.
Yes, you do.
Yeah, I find things get too technical. I was talking with somebody earlier, and I just try to keep it simple. I think that's where my audience focus tends to be. If I was lecturing to more academic, the language is a bit different. But thank you for that.
Oh, you're welcome. I've often had to Google what a doctor said just so I could figure out what did that word mean.
Totally.
Yeah.
It happens all the time, and I just find it just, I don't know, it's just odd when I hear some of these oncologists use these terms that patients parrot it back to me, and I know they don't have a clue what it means.
Right.
They're just parroting a term that their oncologist told them. They're telling me, and I go, "Do you know what that means?" And they go, "Not really." And I go,
right.
"Explain it."
Right. Exactly. in your practice, how long have you been using hyperthermia for cancer patients?
Yeah, so I've actually I've had two kinds of technologies, right? When you say hyperthermia. So the first hyperthermia device that I was using was actually a whole body unit. It was called the Heckle 2000, and so I started using that longer. So probably in around 2010 or like around that period of time. And then what had happened is that I was interested in using another type of device called a local regional hyperthermia. And so I ended up getting that brought into the country in 2014. So the one device that I have is called the Celsius 42. And what prompted that was I had these patients that would say we're traveling to Europe or to Germany. Like one that comes to mind was a patient with glioblastoma that was using that brain cancer and they were taking, say, their chemo pill called temozolomide, and they were traveling to Germany. And then she asked me one day, she goes, "Why don't you have one of these? Like, why do we have to travel so far, to get this provided?" So then that prompted me to take a series of steps. And so I actually ended up applying to our Canadian government. So in Canada, it's called Health Canada. It's your equivalent of the FDA, where they have a special program to allow devices and even medications into the country. So it's called Special Access Program. So I ended up applying for that. And those were some of the cases that I submitted to Health Canada to get it into the country. So it's a pretty big device. So it's not something that I could like piggyback on my back.
Right. Right.
And so, this big thing shows up at the border and they're like, "What is this?"
Right.
So anyway, so that was my process. There's one device that I felt was quite good. There was many other ones on the market then, and this was one that made more sense to me to bring into the country, and it also made sense to Health Canada as well.
Oh, well, very, very good. So that was a bit of a process, and that could not have been an easy process to go through.
No, when you're dealing with government and regulations, they're quite conservative, and so it definitely there was many rejection letters.
Right.
And then eventually, when the language was finalized and the back and forth was finalized, Health Canada was satisfied. That's when they provided approval for importation.
Gotcha. Well, it took a little while.
Yes.
And you're the first doctor that I've spoken with. I speak with Canadian citizens looking for cancer care and alternative cancer care, and so this is the first that I had heard of hyperthermia being used. Most of the time, they were Canadian citizens who were having to go outside their own country, which is sad, to get assistance there. Now, the Celsius 42, does it get up to, was it about 107 degrees Fahrenheit, or how hot is that?
Yeah. So obviously, the device is European, so they use more of that metric.
Right. Right.
The Celsius, right? So yes, you're right. So the name, why they chose 42 was 42 degrees Celsius, which equals, just above 107 degrees Fahrenheit.
Okay.
And the reason why that figure was used was that's what the temperature they felt that is created inside the tumor that causes the most damage to it.
Okay.
And so that's kind of been the approximate temperature zone of trying to target these tumors and have some kind of an effect. So it could be the 107 degrees Celsius Fahrenheit. Some are saying 43 degrees Celsius would be like, what is that, 109, degrees Fahrenheit.
Right.
But so yeah, that's kind of been, when you're looking at the combined data, that's what they're looking at in terms of having the best target and targeting the cancer with a.
And I'll be putting up some video and pictures showing what the hyperthermia device looks like. We'll put that into video. So this would be on, because I'm familiar with full body. So this is directed at the tumor site itself.
Yeah. So I guess thank you for clarifying that. So it's a good question. So yeah. So when I'm bringing up these kinds of temperatures, I'm not talking whole body, because if you're heating up your whole body to those kinds of temperatures, it gets stressful and potentially dangerous, right?
Right.
And so when we're talking these kinds of temperatures, it's more directed at the tumor site.
Okay.
And the rest of the body is not being subjected to like globally, right? So there's a bit of an interesting with the technology. So the use of regional hyperthermia is not new. It's old. It's been around. It's like, discussed even from like the 70s and 80s. And they noticed that when you had, say, a cancer in the laboratory and you're subjecting these beams, so like the device use a radio frequency beam, like kind of like how a microwave heats things up. It's a bit like that. And that they noticed that when they subjected this heat, the tumor cells like had a higher temperature than the surrounding healthy tissue, like by like one degree or two. And the reason for that is that the polarity of tumors is different than the healthy tissue. Okay. So they're different in design, and so they're more heat sensitive and accumulating higher beams and more temperature than the surrounding tissue. Okay. So that's why when you use this device, it's not like necessarily pinpointed like radiation beams. It's like you're targeting a zone. Okay. And so say you have multiple tumors in that zone, it's like the beams are bioaccumulating more into those tumors than the surrounding tissues. Okay. Now, obviously, the technology can really go high. Like if I wanted to really burn somebody, I could. And so there's an element to it where you're also going to like patient tolerance, like how much heat can they tolerate? Right. And so part of the technology with this machine that I really liked, it's got these refrigerated heads. So it tries to keep the skin cool as the beams go. Oh, okay, great. And how long a session? How long does a time frame does a session in the day usually last for the hyperthermia? So usually when you're doing this, it's about an hour, like 60 minutes, right? Okay. And then the key with it is it's like, so more of its general claim to fame is trying to enhance treatments, right? That's kind of how it's more viewed. Yeah, there are some exceptions to the rule, but it's more generally viewed to enhance treatments. So that's why you've seen it used with radiation treatment, with chemotherapy treatment. Now there's discussions with like immuno treatment, targeted treatments, but also trying to enhance other things that you're doing in your clinic, in your facility, right? So there's data using it with vitamin C, for example, or IV, or if you're trying to enhance like other things. So we're doing that with repurposed medications like dichloroacetate and other things. So it's that's how it's generally viewed. But as I said, there are some exceptions to the rule, but it's that's more how it's viewed like globally around the world. That answered answered my question there. So it's done in conjunction. Is this also done in conjunction with chemotherapy, or you mentioned radiation, but is that also done in conjunction with chemotherapy as well? Yes. So like I'll give you an example. There's a famous study that was published for soft tissue sarcomas, right? And it was a multi-centered trial, and it was actually published in like JAMA, and they actually were using it in these higher risk soft tissue sarcoma cancers enhanced with the chemotherapy.
Okay.
And what they noticed is that these patients actually lived longer.
Perfect.
So it's in essence, they talked about it being like a chemosensitizer.
Okay.
And a radiation sensitizer. And I'll tell you how some countries really take this information seriously. So I was talking with a medical oncologist at a conference a couple of years ago, and he was from Switzerland. And they're more open-minded there. They're less polarized with things. And so we were talking about, so he has the same device as I do, the Celsius 42. And we were talking about these soft tissue sarcomas. And you know what he said? He goes, in Switzerland, if you do not have one of those machines, you cannot treat sarcoma patients.
Wow.
Yeah, imagine that, because they go, there's phase 3 trials, like showing that it enhances survival. And then some of the data that they were like looking at it longer term, they were patients like say alive, 15 years later on average, versus the group that didn't have that hyperthermia only 6 years.
Right.
So it's like, that's crazy difference, right? So that's what I mean. That's what's out there. And so some countries, they take that like, well, like this is what's published. You wanna be part of this, treat this, get one of these devices, and
right.
So here I have patients with these soft tissue sarcomas and they never heard of it.
Right.
And which is really sad,
And what other cancers would this be? Was this good for all cancer, or is this for some specific cancers that this treatment would really shine?
So if you're looking, say, from like quote published, right? In terms of published, so it was first used with like say re-radiated breast cancer. These are cancers that were radiated before, and then they realized if they add hyperthermia and radiation to the mix, it works again, or it works better. Okay. Then they were using them for head and neck cancers, right? Then there's data with cervical cancers, like in the gynecological areas. I mentioned soft tissue sarcomas, right? Then you have there's been some discussions using it for brain cancers as well. Wow. And so in reality, those are just ones off the top of my head that there's if an oncologist or someone was talking about evidence, I go, well, here you go, right? This is what's published.
Right.
And then you obviously have, its use in other areas, I would say more experimental, but doesn't mean it's if it's working here and it's working there and it's working here, why couldn't it work for you, in right. these cases? And so in reality, that's why you see a lot of these things used for many kinds of cancers and many kinds of sites on the body.
Okay, and you mentioned that when, let's say, if a patient's going to ask me, they're going, hey, I'm receiving chemotherapy or receiving radiation therapy now. Is this done? Would this treatment be done the same day, or is this done days before, weeks before? How often is this? What is usually an interval that they may be looking at?
Yeah. So the key with these things is closer timing, right? Okay. So for example, when you're dealing with chemotherapy, in the real world, yeah, it'd be nice to do it on the same day.
Okay.
And is that practical for most people? Because they have to leave, say, one place or come here, and so a lot of patients would be doing it the next day or following that period of time. And then with radiation, it's talked as a radiosensitizer, and again, it's about closer timing, just before the radiation to increase that oxygenation perfusion, or after. So say if someone's getting radiation 5 days a week, you'd want to do it at least once or twice during that week.
Okay. And how over what time frame, weeks, months even, or would the treatment be, would you be doing the treatment, the hyperthermia treatment?
Well, like, so it depends on what your goals are, right? And but like in if there was, say, no politics with anything, like you'd want to try to do them, say, twice a week to maybe even 3 times a week if you could. And say if somebody was on a treatment, like say, like if you're trying to treat a case, like say with our tools, you're always giving at least a couple months, right? Just to see what's going on.
Right.
So it really depends on what your goal is of treatment and what you're trying to enhance or to target. So some people, if they're getting short courses of radiation, for example, like say for 1 week, then you could be thinking of treatment for 1 week, maybe a second. If they're doing, say, radiation for 4 or 5 weeks, you're thinking that longer term. If they're on a chemo protocol, like say that's on for 3 months or 6 months, you could be doing it that long, and then if you are, say, like you're on a program with us and we're trying to do treatments for, say, a month, well, we'll use it for that month.
Got it.
And but then there's also this other use with it, that, like, with the technology. So ours is like, an electromagnetic type of technology produces the heat. And now there's these discussions on called like tumor treating fields, right? Where, like, there's been these FDA approved devices, say for brain cancer, where it began, where they're wearing this mesh on their head. It's called the Novacure, or the Optivo, and Optune, sorry, and they're putting this frequency on the head that it turns out it has this anti-cancer potential, and they call it tumor treating fields. Well, it turns out that this technology that we have, a lot of the pioneering oncologists that I knew who had these devices, that's what they felt was occurring as well, before the stuff was published on these other devices. And so now a lot of these, like, so that one doctor in Switzerland that I was talking about earlier, he goes for brain cancer. That's what he feels it's really primarily doing the magic. It's more about this strong electromagnetic field effect, and then the heating effect could be a secondary thing. So it's really interesting. So
It is interesting.
So that's why, like, for example, the other day I had a patient with glioblastoma, and it's been over a year. He's like brain cancer. He's like riding his bike, playing sports. You can't tell. He went through all this stuff, and he goes, "Yeah, I'm wanting to kind of add this on now. Maybe we'll do it for some series, because I think it's that electromagnetic field effect as well. Plus, he's getting other things with it."
But that's great. So and when I'm speaking with cancer patients across the country, and you're hearing, success stories and horror stories, and I, giving people some hope and help out there, is that there's a lot of tools that an integrative and holistic doctor has in the toolbox. It's not just chemotherapy, radiation, surgery. Nor is it meaning that you have to just discard all traditional treatments. Many treatments are used to enhance what they're already doing, like hyperthermia. So I find all this fascinating, and the fact that people are getting help, they're getting their lives back, they're getting their health back. Those are just great success stories.
Yeah, no, and it's what you said, like, is for some reason you'll find that certain countries are more integrated with these technologies than others, and others are more resistant for whatever the reasons are, and it doesn't make sense, because, as you know, in cancer, it should be like, shouldn't the politics be put aside and do best for the person, right? But the politics are quite real, and it's unfortunate, right, that this information is not shared. So I really appreciate that you're just trying to create this awareness and that this information exists, and and there's actually data in this area as well for those who like that. And obviously there's data from our own experiences, probably considered more anecdotal, but when you've been around for over 20 years, you can't help but learn a few things.
It makes it much easier that way. But hearing, I get to hear success stories all the time, and I was just texting, a patient where they're saying, James, there's no evidence of the cancer. So I'm like, hey, that's fantastic. That's fantastic news. So that's what we're wanting to hear, that people are getting their lives and their health back, and there's no reason to once you get this diagnosis to have to throw in the towel. You don't have to do that. There's other options that are out there. You just have to get started on that. And it's a pleasure for me to be able to connect people with with doctors like yourself, where they can go and get this type of help.
No, I think it's great. So,
and so this is also being used in conjunction with other IV therapies. You mentioned vitamin C, that is it also is it enhancing other IV therapies like vitamin C and as well?
Yeah, like there's even been some research like out of Asia where when they're adding, say, the IV vitamin C with a hyperthermia technology, is that they actually notice even some higher temperatures as well.
Really?
So yeah, I think, and that's why you're seeing various centers incorporating those two in tandem, if for those who can. But yeah, it really could be used in many ways. Like, because imagine, say you have a tumor like in your liver, just say, okay, and there's nowhere else, and it's just right there. And when you're getting treatment, you really want it to home in here, into that area. So when you're adding the hyperthermia, they come in these pads that really put the beams in those areas,
Mm-hmm.
So it starts to kind of irritate the cancer. There's more perfusion, more blood flow in that area. So instead of it going to your hands and feet where you don't want it to go,
Right.
And so yeah, like it has these amazing capabilities of really homing in things to enhance all kinds of treatments, and so when you talk about the IV treatments, yes, or other supplemental treatments, yes, or you're doing, certain repurposed off-label meds, yes, you could really home it into areas, and that's part of its claim to fame of the technology.
Now, when you're doing, I've been asked, in regards to questions about, hyperthermia, and I usually, of course, refer those to the doctor, but, questions will come up. Well, what if I just do, get a red light sauna? And how is that in comparison to, setting into a red light, sauna for a period of time? How does that differ?
Well, so I think, so again, like, I think red light saunas and red light infrared, I think those are also great tools as well. So first of all, but in terms of comparing the two, is like you're comparing probably like, a big bomb to a more of a spark.
Okay. Okay.
Like, because with the technology, you're like, there's these massive radio frequency generators in the device that are putting these big, powerful beams that go deep inside you, and so they're deep penetrating. So like, there's been like, so for example, in Europe, like insurance companies could pay for this technologies, right? And what they had to demonstrate that in the beginning when these technologies came is can you get to these higher, like 107 degrees Fahrenheit temperatures? So they actually put probes in there to actually demonstrate that,
Wow.
and so that has been shown, like to get to those temperatures. And as I said, if you did that to the rest of you, you would be in good state of health. You wouldn't be good.
You come out like a baked turkey or something, right?
That's
So
right. So
yeah,
that's what I mean about the technology, right? Is like, it's like a lot of thought has gone into these devices, and to try to make them really safe as well, that these beams go in deep, and they could go in to create these higher temperature zones that these infrared and these other devices just can't do. Not to say that that technology isn't helpful for people, but it's in a different way.
gotcha. Okay, thanks. Because the I'm in Arizona, and I remember having a conversation with a patient. I couldn't stop laughing because it's 110, 115, 120 degrees sometimes during the summer. He goes, "I'll just lay outside." I go, you could do that, but you're gonna have to get somebody with a spatula to turn you over every now and then. But I said those are great conversations with the doctor, but that's kind of a funny analogy that hey, this is not this is deep penetrating that you're just not going to get from a sauna or from sitting outside, things of this nature.
That's right. Yeah, and you're creating temperatures that would be hurtful for the rest of you and the surrounding tissues, and again, more helpful in targeting the cancer itself. So that's what's been great about these technologies, is that, and again, it's not new. Like these research papers have been published many years before, but it just seems like the uptake historically has just been slow.
It does seem slow, and as I'm speaking with patients, they'll go, I've never heard of this, or I've never heard of these other additional treatments. It's simply because their doctor's not explaining it, so they're not. I go, well, if you went into a Mercedes dealership, you wouldn't expect them to talk to you about buying a Toyota. So you're only going to get that's why coming in and getting some additional information and these other second opinions for something to even enhance what you may already be doing. So many patients think that, if I come and I do integrative and holistic treatment, I'm discarding everything else. And I go, no, that's not necessarily the case at all. So a lot of times things are done in conjunction together.
Yeah, like obviously, that's obviously some models where it's like, yeah, integrative with the levels of standard of care. But on the flip side, let's just be honest as well. These, like, I know oncologists, and sometimes they're stuck where they feel the treatments that they're going to provide is not going to help them and maybe hurt them, and they probably wouldn't give it to their own relative or family member, but they'll give it to a patient. So there are scenarios as well where like doing outside of the standard of care is also quite indicated. And let's also be honest, right? Like, I'm in the trenches, right? So, and I'm sure you've seen this as well, where you see some patients given radiation and it didn't work, You're seeing, like, I've seen cases where right where they radiated, tumors grew out of, and then you see other patients where they're given chemotherapy as an example or something, and then the next scan, the cancer is like, the scan is like exploded, right? So it's this really like fine line. Like, obviously the $1 million question is, how do you pick these cases out?
Right.
But I do feel there's a demographic of patients that they have an intuition, like they kind of just know themselves, and so it reminds me, like, say in prostate cancer, like, so when I started in prostate cancer, and this is more localized, active surveillance, so that term, monitoring it, like, these people have prostate cancer, and monitoring it was not a standard back then. It is now, right? So there's a standard now with prostate cancer where if it's a lower grade, they just watch them, they don't treat them, and they just monitor them. Patients of mine, years ago, when that wasn't a standard and they wanted to do that, they said, no, that's wrong. It's like, you're crazy. You're gonna, and then move forward into the future. The same oncologists, say if they're still around, they'll say, you were right, And so, and I have those patients, some of them are still cancer free,
Right.
or with their prostate cancer, it's not doing anything. And they're like living their life, their sexual function's good, their health is good. So it's like, how many other cancers are like that? You know what I mean? Like, and
Right.
so it's this kind of fine line, this legal line. And so that's why for me, yes, a standard integrating with standard of care is probably the more legal, safer ways, and there's a lot of research that way. But there's also, I think, groups of patients where maybe it's not the best for them.
Right. Right.
And you're always walking this fine line with them.
Just start with that. I encourage when patients call in, I encourage them to start with a consult. Start with the consult. I'm here to provide basic information on realistic lengths of stay and cost and things of this nature, so that they're not going into it blind. But these are usually individualized treatment plans. They're I've been in facilities when I remember seeing 3 stage 4 breast cancer patients, and there were some treatments that were similar, but I would say that their overall treatment plan was different. But they were in different, varying degrees of health, and even with the stage 4 cancer. So start with this consult, and start that way. You can get an individualized treatment plan put together.
I think that's exactly right. And you know what's funny? I'll tell you a funny story about that. Is I've done this once and I'll never do it again. I had women with breast cancer, and this is earlier in my career, where she wanted to come with 2 other friends with breast cancer. Okay?
Oh goodness!
So it was 3 of them in one sitting, and at the end of it, what was determined? They were all like all so different from each other.
Right.
And at the end of it, like they all didn't gain much, but all what they did learn is that they were very different from each other.
Right.
And it wiped me out energetically.
Oh yes.
So I said never again. But it was an interesting lesson for them and for me.
Right.
That what you said is bang on. It's very, very individual and customized to every person, and sitting together with them to see what makes sense with them. And sometimes as well, while we want everyone to get along and to agree, it's it's not always the case. What people don't know, I know behind the scene that oncologists fight amongst themselves, and
right.
The surgeons fighting, the they're all fighting, and it's
right.
Oh, me. And so everyone thinks there's this kind of kumbaya thing.
No, it's not.
No, it's not.
I'm laughing at your story, because I've had conversations like that. I think the largest group on a conversation was a group of 11 family members in on a conversation to get they were needing information for their mom. So all 11 were in on the phone conversation, and everybody having different questions and inputs, and by the end I had to have a nap. It was exhausting. It was a little exhausting.
Totally.
Yeah. Well, doctor, I look forward to future conversations and meetings like this with you. And I'm certainly, my hope and prayer is that people get they feel empowered, and they get hope that, hey, even though that I have this cancer diagnosis, this doesn't have to be it. I hope you enjoyed the video. If you're in the need of integrative and holistic treatments for you or your family member, please feel free to reach out to us at findhelpforcancer.com. We'll start with a simple conversation and help point you in the right direction. Happy to help.